Leopoldo Mandic in Campinas. This faculty is the Brazil's most developed research with ultramolar and developed laboratories. Many papers and research are developed by our group in these laboratories. So let's talk about orthognathic surgery. Most people seek us with aesthetic goals treatment to solve dental facial deformities. But it is obvious that the function is so important so as the aesthetics. When I say functional, the goals talk about two situations. The first one, occlusion and upper airways. Like this, the tripod of orthognathic surgeries is aesthetics, upper airways, and bite dental occlusion. This is the Fab Arnett concept. When Dr. Arnett proposed facial, airway, and bite analysis, we began thinking in these three situations together. At the beginning of the surgery, we talked only on the bite. After this, after only in facial aesthetic. Today is all. When you see this picture, we understand what is a beautiful smile with size and form of the teeth, good exposure, beautiful color, good teeth inclination and angulation, good anatomic gun, outline and color, but it wasn't always like this. The previous smile is that of this patient after orthognathic surgery and dentistry correction. The treatment is all integrated. When I started to perform orthognathic surgery, the patient was very dissociated. 10 years ago, me and my team started a flow that involved different specialists. Who won with this? The patient, obviously. Today, the goal is patient fast recovery. So, to do this, the first step is family support. Yeah, the family needed to be help the patient, needed to give care. And the first specialty is psychology, to explain and understand the surgical process. The second step is virtual surgical plan. The software are tools can to add to our planning. Easy to understand the movements in the three planes of the space. Check the bone interference and the great accuracy. The third step is contemporary orthodontics. I learned to work with few orthodontists who treat dental facial deformities. I understand this. Specialty orthodontic is as important as mine in the treatment of the dental deformities. Regardless of orthodontic techniques, it is important that the teeth are aligned and the arches coordinated. My best results occurred when the teeth is well positioned. The fourth step is contemporary anesthesia. We use permissive hypotension, lowering mean blood pressure values, and this reduces the postoperative swelling and help fast recovery or fast track. And obviously, reduce the transoperative bleeding to help use the transamine during the surgery. Okay. As important step is the surgical technique, minimally invasive philosophy. Not everything that is recommended, but smaller surgical approaches, smaller tissue detachments, and changes in the design of osteotomies. We will say this later on. The last step is about a good nutrition and physiotherapy. We have a physical therapist in our group, yeah, and she started the process in immediate post-operative in the operating room. This provides post-operative improvement, lower levels of pain, and recovery of masticatory movements, and more fast facial mimicry. So today, I understand multidisciplinary treatment is mandatory. Okay, so let's go to the 4 protocols I have been used. The first protocol is about diagnosis. The second about planning. The third about surgery, and the last one about post-operative. What's the meaning of the protocols? The goal of protocols is keep a routine, make the route more stable and reliable. Let's talk about each one. To make the diagnosis easier, full diagnosis should be established from simple and effective analysis. For this, I use a mixture of analysis of several authors, forming my own way to analyze. So it is necessary to do the list of issues: facial issues, teeth issues, upper airway issues. From experience, the patient's complaint is my guide to perform the surgery. I try not to start the consultation talking about the problems that the patient has. I try to guide the anamnesis so that it understands the general context of dental facial deformities. The focus is on complaints. My gums appear too much in the smile. My nose is drooped, my lip is thin, my chin is big, I don't breathe properly. If the patient says my chin is back, so I can guide the interview, answer about sleep quality, bite efficiency, and some breath difficulty. I'm very happy and proud to learn with Masters of Oral and Maxillofacial Surgery. One of them, Dr. Larry Wolford, I stayed with him in Dallas, USA in 2019. And I use a lot of measurements, cephalometry and facial analysis. The third of face, the proportion, the lips relationship, it was published a chapter in Miloro about facial analysis by Dr. Wolford. I have been used the chin height, the occlusal plane, the linear distance of upper airway. I no longer use measurements such point A perpendicular to N, point B perpendicular to N, and Frankfurt horizontal plane to evaluate the profile. I use the natural head plane from proposed by Arnett. The occlusal plane angulation is very important. Its variation, 8 more or less 4 degrees, ranging from 4 to 12 degrees, is mandatory in the clockwise and counterclockwise, the chin position, the open upper airway, the incisors position, and the profile of a smile. So, I am a personal friend of Dr. William Arnett, and I'm learning to use the most measurements proposed on his book. So, I apply FAB concepts in a lot of cases of dental facial deformities. And here you are, in São José dos Campos, Brazil, in 2017, my teammates Leonardo, Christian, Julia, with Dr. Arnett and Dr. Doug McKnight. So the FAB concept is not about airplane Brazilian Air Force. It's about facial, airway, and bite from Dr. Arnett. To understand the problems, we need to understand what's normal. Yeah, to have a beautiful profile, we have a vertical true line and its relationships with lips and chin. So the upper lip is near 4 millimeters in front of the line. The lower lip, 0 or 2 millimeters in front of the line, and the chin, 3 millimeters behind the line. This is the goal. About airway, the linear distance is 11 millimeters on oropharynx. And no, so important, the bite, we need a good occlusion. She's a beautiful woman, no? A Brazilian model, Gisele Bündchen. The Tom Brady is a look guy. And what Tom Brady saw in Gisele? A good mandibular length, the proportion of facial thirds, and a special nasolabial angle. Tom is a smart guy. Another important measurement is the incisor exposure with lips at rest. 2 to 4 millimeters is very acceptable to young guys. During the smile, we need to evaluate the incisor exposure with the total teeth crown exposure, or 1 or 2 millimeters of gum exposure, and the smile contour with the premolars appearance and the occlusal plane. This exposure will determine the beauty of smile with good position of the maxilla and the teeth. So it's our goal when we correct the maxilla position. She is a patient who made the orthognathic surgery. Pay attention. The good profile is associated with the incisor angles. We use a measurement described by Arnett as 57 degrees of upper incisor in relationship to maxilla occlusal plane and 64 degrees of lower incisor in relationship to mandibular occlusal plane. So the best results in profile need good inclination and angulation of the teeth, particularly the incisors. The A from FAB is about the airway. It's well documented in the papers about the benefits of the orthognathic surgery in airways. Look at this paper from 2018. The authors evaluated the changes in the upper airway after maxillary advancement, mandibular advancement, and bemaxillary advancement. Evaluated in CT cone beam, they found 41% increase in upper airway when they did maxillary advancement, 21% when they did mandibular advancement, and 66% in bemaxillary advancement. The second protocol I have been used is about planning. To plan, I have been using few cephalometry measurements. My first step is use facial reference. Based on facial analysis, in every case we do virtual planning. The most of cases we do changes in occlusal plane, both clockwise then counterclockwise. And about the reference, my most important reference, in my opinion, is the upper incisor position. This tooth gives the three-dimensional position of the maxilla. So everything follows this. Upper lip, lower incisor, tip of the nose, occlusion, chin position. Today, we need to associate very aesthetic procedures with the orthognathic surgery. We can do rhinoplasty. It's not our routine in Brazil. We do this separate in a second time. We can do liposuction and lipotransfer. We can modify osteotomies to improve aesthetic and others. A few years ago, we used drawings to outline the soft tissue profile, the teeth, the maxilla, mandible, and skull base. In cephalometry, I have used only occlusal plane angle, Frankfurt-mandibular angle, and chin height. These measurements described by Dr. Wolfer. Look at this simulation and its relationships of lip and chin to vertical true line. Look at the counterclockwise rotation. The measurements obtained are used to do model surgery, these measurements. The soft tissue profile is aligned to a vertical reference, as same the vertical true line of Dr. Arnett. So the models mounted in articulator are studied. We use the three spatial planes. The model are moving to desired position. The measurements about previous study are put in the articulator. The original models are cut and moved to the new position. Then we made a surgical guide in laboratory. This process lasts about 1.5 days, so it's too slow. Since 2017, we do every case in 3D planning. So in my planning protocol, I use the virtual planning in every case. We do a CT, scan models, or scan teeth. In this case, I use scan teeth with the intraoral scan, and put both in a software to planning. We call the composite skull. There are numerous softwares for this type of planning. I'm from Brazil, so the cut of maxilla, mandible, and chin are yellow, green, and blue. Some measurements are did in the software in every space plane. Look at measurement of midline of teeth and chin in relation to mid-facial line. So we can diagnose maxilla and mandible deviation. We do measurements of lips and chin relationship, use a vertical true line. So we need to put the composite skull position in the software, just like the head during shooting. We can analyze the upper airway. We made few cephalometric measurements. They are occlusal plane angle to Frankfurt plane, Frankfurt mandibular angle, and chin height. Look, it's not necessary to put the jaws in a perfect angulation, but these angles are good reference. Good tools are the occlusal plane rotations, both clockwise and then counterclockwise. So we can put the reference point to rotation the maxillomandibular complex on the upper incisor. And this is my best reference to do the movements. We can put chin forward or backward. We can use anterior nasal spine and then rotation, or we can use posterior nasal spine. In software, we can analyze the incisor angles, the upper incisor angle to occlusal plane of the maxilla, and the lower angle to occlusal plane of mandible. Remember the measurements recommended to RMED, 57 degrees to upper, 64 degrees to lower. So look at the movements: maxilla forward, mandible backward, correction of midline chin, and counterclockwise rotation. The 3D plan had to view osteoclastis as the lower edge of the jaw with this simulation. The splints are printed. Remember, I make my plane using maxilla first, put the incisors in the best position, then I put mandible in a good occlusion, but the most of my surgeries, I do the mandibular movements first. So the first splint is used when I operate the mandible first, okay? In this situation, when I have large asymmetries, I still begin by the mandible. I think it's more easy to correct. Due to the fact that I'm slowing down my surgical approach, I slow down my detachments, and it's more difficult to do my osteotomies because I can't look all structures. So I like to use this kind of guide. I don't need to take much detachment. I don't need to locate mental nerve. And I use approach with tunneling. So I expect less paresthesia and more precision in the osteotomy. Today I have used the minimally invasive philosophy with minor approaches. Before planning, after planning, the planning and the result, the surgery result. Look at the good result. Look at the edge of the jaw, the good osteoplasty. Before planning and the planning and the result. My third protocol is about the surgery and all procedures involved. Everything in transoperative care, in surgical technique, in fixation of the osteotomies, and aesthetic procedures. Let's talk about this. A lot of procedures can be done associated with orthognathic surgery, as osteotomies and a lot of designs, customized processes, different kinds of fixation, liposuction, lipo transfer, and others. Let's talk about technique. During my career, I have performed different drawings in surgical osteotomy, since Epker modification, passing to the Tucker linear osteotomy. Then I have been used today the long and short medial cut described by Posnick in 2019 and published in 2021. Smaller approach, smaller tissue detachment, and smaller osteotomy. The authors say this osteotomy promotes decreased interference between segments. So I have used this design. Below alveolar nerve intake, the forward up to the second molar with a linear cut It is easy to position after advancement and to fix with plates by intraoral approach. Another important paper is about rhinoseptoplasty and orthognathic surgery by Ruffin. With a smaller approach, they do an osteotomy down to anterior nasal spine. The subnasal osteotomy allows to do rhinoplasty with orthognathic surgery. In some cases, I have used this subnasal osteotomy because the changes in the tip of the nose and the columella are small. So this is an example about smaller approach, extended from canine to canine, and subnasal osteotomy. As I said earlier, I have used this guide to smaller tissue detachment and nerve care. It assures my osteotomy down to the nerve. Let's go to the case. This case has 10 years. This one is a woman with vertical excess of maxilla, jaw deficiency, lip incompetency, asymmetry smile, large gum exposure. The orthodontic treatment with the compensation of incisors, the cephalometry with small upper airway, the prediction tracing, look the movements in maxilla and mandible in counterclockwise, and the chin projection. Intermaxillary fixation using hooks of the orthodontic appliance. The guide is extra hard silicone. We published about this guide in 2010, but today it's not acceptable. But we had the good results. We began the surgery with sagittal osteotomies. In most cases, we used 2 plates, according with Dr. Arnett. But we used, in some cases, hybrid technique with one big cortical screw and 1 plate, or we can use only 1 plate. It's been a few years since we have used 3 bicortical screws. After the sagittal osteotomies, we do the 4-1 osteotomy. Look the bone piece removed to put maxilla up. We did the 4-1 osteotomy with a large detachment, molar to molar, a big approach. Look the segmentation of the maxilla in 4 pieces. We have used a lot this technique. The bone turnover increased with this segmentation, facilitating the orthodontic finishing. The final splint and a fixation of the maxilla with 4 plates. So we got a good result with lips contact, facial proportion, a beautiful smile, the good gum exposure, the transverse plane correction, good midline, and good mandibular contour. Good smile. On profile, look at the correction of nasolabial angle, balance between the facial thirds, perfect lips, and chin relationship. At this time, we could do liposuction in Brazil 10 years ago. Today, we can do liposuction because our dental advisor authorized do. So this case need this procedure. In profile, look at the good advancement with counterclockwise rotation, with chin projection, and excellent gain in upper airway. The final occlusion, the final bite, the good smile contour, an excellent incisor exposure. Remember, young guys, we hope 2 to 4 millimeters of exposure. So our team planned oral rehabilitation after orthodontics device remove, the virtual plane, and the aesthetic crowns in anterior teeth, the 4 incisors. Next case, a young guy, her complaint was lips incompetence, jaw deficiency, oral breath, bad sleep, and big gum exposure. In profile, we can see the poor mandible, vertical excess of lower third, and round face. The orthodontic treatment to put the incisors in good bone relationship and good angles to occlusal plane. We put in the CT and scan in software, draw the osteotomies, and take the measurements. Pay attention in Frankfurt mandibular angle and occlusal plane, both greatly increased. Poor array, we planning through the maxilla first, but the surgery was made mandible first. Look at the intermediary guide to fix the sagittal osteotomies in mandible, in jaw. Maxilla up, look the need to perform open repair. When you put maxilla 5 millimeters up, we need the most case this piriform plastic, piriform repair, and remove of lower shells, lower nasal shells, and the nasal septum correction. So look the final guide to fix the maxilla. We did the sagittal osteotomies, put the intermediary guide, and fix the mandible. The hybrid technique with 2 bicortical screws and 1 plate in both sides. Our team have been studying fixation a lot in orthognathic surgery. In this paper published in 2014, we tested the influence of SSRO, sagittal osteotomy, designing in vertical forces. Using one single plate, we made 2 groups. The first group with the angles by Epker, and the second group by a linear osteotomy by Tucker. 3 subgroups: the subgroup A without advancement, the B with 3 millimeters advancement, and the C 7 millimeters advancement. And the results showed the group 2 with greater resistance. We have been used linear osteotomy in the most of our cases during several years. Continue. Leforone osteotomy with large detachment. Look nasal septum separation. The final guide, intermaxillary fixation, and Lefor 1 fixation with plates. 4 plates and bichectomy, buccal fat pad removed. Finally, we fix the chin with a prevent plate. Before and after, good aesthetic result. Before and after, the good lips relationship, the facial harmony, the final dental occlusion. And this patient is very happy with the result, enjoying life. In Brazil, we have a lot of class 2 malocclusion. One more, vertical excess, jaw deficiency, great bigger gum exposure, oral breath, lips incompetency, asymmetry. In profile, we can verify the jaw deficiency, lower lip and chin behind the vertical true line. Prepared to surgery, but without a good discrepancy. So to put mandible forward, we need occlusal plane rotation. In virtual plane, we can see asymmetry, midlines, deviation, and a big maxilla. The virtual correction placing midlines coincident with facial midline, reducing the lower third height. Look occlusal plane, Frankfurt mandibular angle increased, occlusal with 23 degrees and mandibular with 41 degrees, when a normal occlusal plane is 8 more or less 4 degrees, and a normal mandibular angle is near 25 degrees. As the chin height to young women, we expect near 40 millimeters. In this case, we have 46. These measurements shows why the patient had a vertical excess in lower third of face. The corrections reduce vertical chin and counterclockwise rotation. And the guides, the two guides. In this case, we prefer start by maxilla, do the guide grade thickness if we start by the mandible. So if you start by maxilla, the thickness of a guide will be small. Let's go. The patient did the previous maxillary expansion in the first time, and we made the forward osteotomy. The internal vertical reference, we do 2 perforations with drill and measure the distance on both sides of maxilla with a compass. The measure will help to put maxilla in correct position when we need vertical movements. Bone remove, because we will put the maxilla up. Down fracture, piriform plastic to gain airway space. Look at just of nasal bases. We remove bone with burr. The intermaxillary fixation. So today we have been using screws to do this. We're not to use orthodontics appliance anymore because I don't like when this appliance break. The maxilla fixation with the 4 plates. Look at the big approach. So we go to the mandible and go and do the sagittal osteotomies. Put the final guide intermaxillary fixation. So we put this plate to advancement, to mandibular advancement, a good option, but I can't be used this plate in every case in Brazil due to economical questions. The other side, pay attention, the large detachment, mental nerves, do chin osteotomy to height reduce chin advancement, a good result. Final occlusion, the same occlusion was planned. So we can see lower third reduce facial harmony, lips closure. Counterclockwise rotation, chin projection, lips and chin in relationship to vertical true line. Final fifth occlusion, a good result. We can see previews, the planning in software, and the really result after 2 years. Initial planning and final result 2 years. Planning and CT after 2 years. Planning and the result. The increase of upper airway. Another case, class 2 malocclusion, to plan using the same measurements and the same protocol. Lower third lower third height increase, maxilla deficiency, and mandible excess. open bites and class 3 malocclusion with unevenness occlusal plane. After orthodontic repair, worst case after orthodontic repair, the same open bite. We need under the natural camouflage. So the plane was clockwise maxilla rotation 8 degrees, paranasal advancement, mandible we plane 4 millimeters backward and base osteoplasty to contour, and chin put up 3 millimeters. A profile correction of the vertical excess. We do the sagittal osteotomies, put the first guide, then we reduce the bone excess, put 2 plates in each side. The final guide and the 4-1 fixation. We did bichectomy in this case. Finally, we reduce the chin, look at the large detachments. Our result and our team in this surgery look, even with bigger approaches, we have little swelling. Postoperative 60 days. A good result. More facial harmony. A good profile. The next case is a guy with a jaw deviation to the left, asymmetry, smile, and maxilla deficiency. Use the vertical true line, you can see the maxilla backward. I see 2 difficulties in these situations, in these asymmetric cases. First, the head position to plan the surgery, yes, so difficult. And secondly, nasal problems. As deviation septum, so we need to be careful to do this. The orthodontic prepare, we plan the case in software. No doubt that 3D plan help a lot in asymmetric cases. Look at the correction of the maxilla with segmentation. The most difficult part is the chin in this asymmetric case because particularly during the surgery, to put the chin in the best position. In profile, we do the maxillary advancement with clockwise rotation to put the chin back. We can remove mandible to see the shape of the upper arch. Then compare the beginning and the planet. The guides, we begin the surgery by mandible. Sagittal osteotomies, intermaxillary fixation. We put 2 plates in each side. The 4-1 osteotomy with segmentation. We have an asymmetry in the anterior nasal spine, a large maxilla exposure, buccal fat pad removed to best facial contour. The final guide in this picture, we can see the problem when I use orthodontic appliance to do the intermaxillary fixation. The brakes take off. Preform plasty, fixation with 4 plates. So we did the chin to put a graft to help in asymmetric correction. We have before planning and after. Before planning and after, before planning and the result, a good result. So difficult case. Look, the result and the asymmetric correction. She did a rhinoplasty after orthognathic surgery, a good correction of midline. Beautiful smile, you can see a poor movement of the orbicular muscles. So I think I need to do something different to solve this situation. A beautiful profile, look at large exposure of lower teeth I don't like this. The final occlusion, the final bite. One more case, maxilla excess, big explosion, lips incompetence, mandible backward, poorly marked mandibular angle, bad relationships of lip and chin to vertical true line. The upper first premolar was removed in both sides, changed the inclination of teeth, so the angulation of the upper incisors to maxillo-occlusal plane was increased, and this affects the lip results. Then we need segmentation of the maxilla to correct the incisors angulation. We have a poor upper airway. Again, we start planning by the maxilla, but the surgery we start by the mandible. So you have the surgery of the mandible and the first guide or intermediate guide. The plain L4-1 osteotomy with its segmentation, and the final guide was made. Bilateral osteotomy, sagittal osteotomy. We put the guide, fix the mandible, and we use the kind of plates. We can use this kind of plates called the grid plate to advancement. It's a good option. Look at the conference of the sagittal osteotomies and the same gaps in the virtual. To the maxilla segmentation, you have to use the piezo surgical. This provides more safe to cut maxilla bone, preserving the palatal mucosa. We do the H design with two parallel osteotomies in the floor, in the floor of nasal cavity. These osteotomies come down into lateral incisor and canine in both sides. So they are united behind the nasopalatine foramen. L4-1 osteotomy with fixation the chin correction with advancement, pre-bent plate, 15 days post-operative, a good result, little swelling, so we can see that tissue manipulation is very important for a good post-operative. Good profile, good lips relationship, correction of the incisors angle, 1 year post-operative, beautiful smile, excellent profile, angle, mandibular angle well marked, and the case stability with a good occlusion. So after 6 months, we do the orthognathic surgery of your twin sister. Yeah, twin sister. The same problems, but not the same face. Mandible deficiency, no premolar extraction, practically class 1. So to get results in this situation, we need occlusal plane rotations a lot, 3D planning, the planning with reduction of vertical excess, and the good result. Before and after, a good profile, and the mandibular angle well marked. And a few months ago, they got married, and I was invited to go to the wedding. When the minimally invasive philosophy was very important to my surgery. Yeah, in this case, this guy has Moebius syndrome. It's hairy and it's known to have a progressive facial nerve degeneration, paralyzing all muscles of facial neck. So it's difficult to open the mouth. Convex profile, class 2 malocclusion, poor airway associated with the chin backward, the asymmetry correction, mandibular advancement and counterclockwise. Start the surgery by mandible, small approach with a small detachment. Left for we use the small approach too, and the chin advancement, pre and post-operative, good profile, is in orthodontic finalization. Condylar changes. We send to publish this paper about three-dimensional evaluation of condylar changes after orthognathic surgery in patients with malocclusion class 2. So, among all measurements, we found three results. We had decrease in left condylar volume without correlation with type of tip or fixation and without clinical manifestation. It is more common today to associate other techniques with orthognathic surgery. One of the most important are the liposuction and the lipo transfer. This is easy to do, but it's necessary large knowledge to do. Need to understand the tissue plans, muscles, positions, and fat location. This fat was transferred to another place to fill and stimulate collagen production in the skin. The fat manipulation and the lipo transfer to fill this area. So we have a woman with maxilla deficiency, lack of lip support and excess submandibular tissue. 3D plan with maxilla advancement, clockwise rotation, posterior reposition of the chin. The facial results in 10 days post-operative with filling in the paranasal area in the infraorbital region. Good results in 10 days. The minimal invasive philosophy is good in this situation. Early returning of mimic movements. In 10 days, the lips are not fully functional. We need 4 to 5, 6 days to the best results. And this patient is very happy with the results. My last protocol is about post-operative. And it says to good nutrition, physiotherapy, and complications control. Nutrition is very important to patient recovery. For this, we need a little post-operative swelling, post-operative without pain, and good muscles movements. So we treat the patient with dexamethasone for 3 days, opioid analgesics, and no non-steroidal anti-inflammatory drugs. The physiotherapy is one of the most important steps in the treatment. Yeah, the most important, one of the most important. The laser therapy, the lymphatic drainage, the muscle strengthening are fundamentals to fast recovery of the patient. Complications as infections, pain, bad occlusion, post-operative and others need to be controlled. Anesthesia is good in the first moment because no pain, without pain. But as the days got by, it starts to be inconvenient. So we need to try control. This is a good case, for example. Class 3, maxilla deficiency, chin deviation to midline, and tip the nose down. Maxilla deficiency, chin projection. Prepared to surgery. The 3D planning. Start the planning by maxilla. Put the upper incisors in the best position. Guide to chin osteotomy. Put the mandible in occlusion and correct the ramming positions. We did the surgery with minimally invasive philosophy and the planning and the CT results. In the operating room, before extubation, the physiotherapist, Dr. Delaney, began the work. First day post-operative, a good result. 7 days. 7 days. 14 days. The sutures, pre-operative, post-operative, 14 days. Good movements with mimic muscles. An excellent profile. And a good repair of the small approaches. To finish, my conclusions are the principles of a surgical technique are more important than the minimally invasive philosophy. If you take care of the hard and soft tissues, the post-operative will be good. Today, we need fast recovery in our words. Everybody needs to be reintegrated into society soon, and no doubt we need more than surgeon to treat the surgeon and orthodontists to treat dental facial deformities. This is my seat today, Piracicaba, São Paulo State. Again, Dr. Parky, thank you for your invitation. I will always be available when you need it. This is my Instagram and my email. Thank you for your attention. I'm ready to